I've had conversations with my nurses, with the residents and all, and it just becomes a situation where you can't really find good, reliable information, especially on social media nowadays. So let me kind of use my influence to some degree. At least I know my voice is more trusted in this space and compared to some other people. So
Yeah, so
that's
they
how it
say.
started off. So they say. So they say.
It's a tricky ground, Mark, as you well know. It's a very tricky ground. There is no monopoly on truth.
Oh.
There is an absolute truth, perhaps, but who has a monopoly on it? I don't know.
Yeah, truth is truth. The question is whether or not you're going to highlight the more truthy aspects of it or use it as a kernel of truth and go on somewhere else.
Yeah, and we also, all we can do is present what we know, why we know it. That's an important part, why we know it. And persons are now able to make decisions. They don't have one source of authority, and their sources of authority have fractured, and they fractured because of the social media aspect of it, right? Legacy used to be the only way to deliver information, and now we have so many different ways of doing it. So the forest has gotten thicker, and here we are trying to put a beacon of light through there, huh?
My program director in residency said, he always said, be a candle in the darkness. That was his theme. So yeah, here's my offering to the darkness. Welcome, everyone, to this episode of the JAFERD Cast. I am your host, Dr. Mark Papadakis. No one particularly special, just another fucking ER doctor. This week, we have my old mentor, Dr. Michal Tracz, here to talk about all things hypertension related, well, most things hypertension related, and even little tidbits about medicine in general, what we go through with training, and tips for even some of the newer docs coming up. It's going to be a fun cast. So with that said, let's bring him in. All right, welcome everybody. I'm here with my guest for this week, Dr. Michal Tracz. Dr. Tracz, hello, how are you?
How are you doing, Mark?
I'm doing fantastic. Long time
Yeah.
no see. So first of all, tell us about yourself. Where you went to medical school, where you trained, your specialty, all that.
It's funny how we say that. Medical school does not matter. For anyone who's listening who wants to, wonder what to go to med school, whatnot, you go to the cheapest med school there is, that it's stateside. Yeah, that's important. But medical school doesn't matter. I went to Stony Brook Medical School, very nice, but it's irrelevant. Now I'm going to say something very, very controversial. Residency is important, but that's not where I became a doctor. I became a doctor in the midst of the nights as a moonlighting fellow. That's when I became a doctor. For the first time, when you become somebody without direct supervision over you, and you're in the middle of the night, and yes, there is theoretical backup, but there really isn't. It goes south, and this is you and the hospital, and basically this. So I did my residency at Mayo Clinic, but I became a doctor as a moonlighting fellow in the heart of darkness, in the middle of the night at Mayo Clinic hospitals. I was covering two particularly difficult services for a long time: hematology oncology service at Rochester Methodist Hospital and cardiology service at St. Mary's Hospital. So that's when it hit the road, Mark. That's when it became.
And I think you used to say to me, or us, I should say, because you were a mentor for not just me. I say it's like me, but you were.
It was just for you, Mark.
It was just for me. That's right. You mentored third-year medical students. Still do.
Yeah.
In a way. I remember many days, Monday mornings, you come in, we'd lecture, then you take the students who are on their internal medicine rotation and say, all right, come with me. We're going consults, we're going to my office, we're going to wherever. And you taught them, nephrology, you taught them a lot of internal medicine, but you also taught them about life. And that, what you just talked about was one of your life lectures. I know that very well. And I remember one quote that you used to say to us a lot was, every physician carries their own graveyard.
Yes.
The idea that you learn from your mistakes, and we as physicians, we make mistakes, and those mistakes kill. And it's unintentional, but people, I think, sometimes have the impression that we kind of move on. Like, oh, oops, it's a mistake. Sorry. No. And the answer, it's no. We carry the names, we carry the faces. If not the names, definitely the faces, definitely the moments where we realize we did something that caused harm. Maybe not death, but definitely harm. And so that's the graveyard that you always have in the back of your mind when you're practicing. As more experienced attendings have, unfortunately, the bigger the graveyard grows. And it's sobering to think about. It's scary for a patient to think about that too. That, this person has caused harm. And the answer is, every doctor you've met has made a mistake in their career that has caused harm. But that's,
Correct.
in a way, that's how we've grown as physicians. That's how we've grown as a medical profession. The people who say they haven't hurt anybody are lying to you.
Yeah. So this is a mantra that I carry. I mean, I continue to teach, Mark. Yesterday we had five students who went over things. I always tell them the same thing I've told you. I guess something I've learned my hard way is that this is what distinguishes us from civilians, quote unquote. I use that term because I really feel, especially after the quote unquote battles of COVID, that there is a distinctive difference between, the military and the civilian, the police officer and the civilian, and the doctor and the civilian. And our specific thing is we have seen darkness, if you will. We have seen bad things happen to people a lot. And sometimes we have been the cause of those things. And yes, the guilt carries. And it is that guilt that makes you a physician. You don't become a physician when you get hood, as you well know. You've now practiced for a long time. You know exactly what I mean by that. You don't become a physician when you get that hood. The people start calling you doctor. You feel like an imposter for a long time.
I still do.
Moment. Yeah, well, yeah. I still do too, I guess sometimes. Actually, no, I don't anymore. It goes away, Mark. It goes away.
There's a quote, apparently, I wish I could remember the source from it, but there's a story where a person was at a conference somewhere, and there's a bunch of, I don't know if they're PhDs, business people, donors, whoever what it was. And this person was in the back of this room looking at these people, and an older gentleman comes up to him and says, man, I don't know why I'm here. Look at these people. These people, they have doctorates, they cure disease, they've done whatever. And the person who's telling the story looks at him and says, what are you talking about? You're Neil Armstrong. Of course you should be here. The idea that Neil Armstrong is at an event where he feels like he's an imposter could kind of reassure all of us that maybe we're not as much of imposters as we think we are.
Yeah, and it takes time. It takes time to develop anything. The competence that we develop, the sets of competences. And we develop two things. We develop a set of knowledge competence, if you will, learning the books and so on, but we also develop that sixth sense that distinguishes a more experienced doctor from a less experienced doctor, walking into a room and knowing what's important. Sometimes you will ask different people with different levels of experience and they'll tell you a different thing. A simple example, you walk into a room, a critically ill patient on a ventilator, you'll ask the trainees what's important, about the vitals. What's important is that this husband holding this intubated woman's hand is ready to let go. That's important in the room. And then you focus away from the screen, put a hand on his arm and say, it's okay to let go. So this is the kind of stuff that happens. This is what the physicians do. What they learn over a period of many years.
Yeah. Many years experiences. You talk about the idea of helping somebody to let go. And there's a human touch that I think people get the impression that it's missing nowadays. And it's not missing. It's still there. Mm-hmm. We have been inundated with, for lack of a better term, fluff. Really, it's bullshit, but we'll say fluff. Mm-hmm. With regards to billing, coding, metrics. So we have metrics that we're meeting, and a lot of us now are cogs in a wheel. The idea of physician autonomy from even 20 years ago is gone, let alone 50 years ago, where a lot of us are employed and we have people higher up than us saying, you got to do this, we have to meet this, you got to sign this. And so that's pulled us away from the bedside in many ways. And it gives the impression that physicians are not interested in the people aspect of it anymore. And that's, in my opinion, not true, because the loss of that people aspect, the loss of that connection is why so many physicians are burning out younger and younger, and why they're leaving medicine younger and younger. So to hear that kind of a lesson, a story, should reassure people that no, we still care. We absolutely care more than we ever did because of COVID in many ways. And ideally, that's one of the ways we show it, by teaching our own students, our own trainees, don't look at the number, don't look at the screen, look at your patient, look at the family. Treat the patient, not a number. That's something I harp on all the time. And it's something that I think has to be beaten out of some people when they're training, because they're so focused on the number. No, treat the patient, look at the patient. The number is a symptom of the patient. Treat the patient.
Right. Yeah. And there's also an aspect of, we could have a whole another discussion about doctor burnout and what I think about the ways to mitigate that. So let's not even start the discussion.
We'll say that for Doctor's Day next year. How's that sound?
Yeah, that's fine. That's fine.
You're a nephrologist. For those who don't know Latin terms, basically you're a kidney doctor. You focus on the kidneys. You did training for the kidneys, and your practice is focused on everything on the kidneys. First of all, we're here to talk about hypertension, not the kidneys. So why are we talking about hypertension and not the kidneys? Or are we talking about the kidneys?
So what's interesting about that is patients are very surprised when their cardiologists refer patients to me to take care of hypertension, because the natural thing to assume is the cardiologist would take care of that, since the heart just kind of seems to be the organ that's responsible. Mm-hmm. Turns out that the heart serves at the pleasure of the kidney, as you can say. In other words, kidney has a hormonal mechanisms in place that control hypertension, and they control the hypertension through three distinct mechanisms. One is how hard the pumping of the heart will be. Two, how much fluid there will be in a system to either keep the vessels nice and soft versus very engorged and, with high pressure inside. And three, the hormones control the vessels themselves, how pliable they become. Our vessels are living organs. They're not just lead pipes. They can expand and they can collapse, and they could influence the ease with which they do that. A young, healthy patient has vessels that are pliable and able to receive a lot of extra fluid, if you will, without creating the pressure. So if this is the vessel of a young person, if that person eats 2 slices of pizza and then drinks a lot of water.
Why are you harping on pizza like that? Come on.
Well, we'll talk about that. After they do that, that water enters their system and their vessels basically expand, leaving the pressure inside of those vessels the same, 120/80, let's just say. Versus a person who has hypertension as a disease, same pizza will introduce the same amount of water inside of the vessel, but now the vessel cannot expand as much, and therefore the pressure inside of the vessel has to go up. So kidneys really are responsible for all of that. So that's why it's us.
So the kidneys, one thing we learned is one of 2 filtering organs in the body. Your liver is one, kidneys are the other. Kidneys obviously do the fluid. Liver does more of your poisons, your toxins, your all that kind of stuff. If you drink a gallon of water in the span of an hour versus the course of a day, your kidneys are the ones that are responsible for saying, okay, you just gave me a whole gallon of water. We don't need all this. So guess what? We're going to the bathroom now. We're going to take more trips to the bathroom.
A loaded statement, Mark. A loaded statement.
I'm going to give you a lot more loaded statements. You're going to dissect them.
So there's a lot of toxins that kidney take care of as well. There are different types of toxins, if you will. But the kidneys take care of the toxins who come specifically from the metabolism of protein. We call these molecules, there's about 100 of them. We call it the uremic molecules. We have chosen one of those molecules to measure, so we don't have to measure 100 of them. We chose that one to be called blood urea and nitrogen, and the term we use is BUN. And that's how we know if somebody did a lot of reading on Google. When you say BUN, that means you read it. When you say BUN, that means you went to medical school. But anyway, so that's what they do. As far as drinking a gallon of water is dangerous in an hour. It's dangerously close to a place that will kill you, and your kidneys cannot help you with that because they will quickly overwhelm your internal water distribution. Too much of that water would quickly go into the brain. Whole another topic, hyperemia and so on. But what you're really asking me, what if I would drink a gallon of not so much water, but something salty? Because that's the question here, is not so much water, but something salty. That's where the pizza came in earlier. So it's either super salty and drinking water with it, or drinking things like Gatorade, or drinking hot soup. Yes, it will be the kidneys that will sense extra fluid and start making extra urine. Yes.
But let's say I'm dehydrated. I feel dehydrated, right?
Yes.
I need fluid. And they come into the emergency department and they say, Doc, I think I'm dehydrated. Give me fluid. And I say, okay, here's a cup of water. And they look at me and they do this. They look at me and they say, well, I think I need IV fluid. And I say, well, you don't. People are under the impression that if I'm dehydrated, I need fluid pumped directly into my veins. And they don't understand the idea that if you're dehydrated, your kidneys are the ones that take whatever you're drinking and distribute it evenly across your body far more efficiently than I can do it in an IV.
Yes. Yeah. I mean, it kind of depends on how dehydrated they are, quote unquote. If their blood pressure is super low, I'm sure you would know to put it in. But usually drinking of water and the word terms of dehydration and stuff are really interesting and tricky subjects. Again, an hour's lecture on that, because dehydration is a misnomer of sorts. When patient comes into you with a dry mouth, let's say low blood pressure, dizzy, lightheaded, and they say to you, I am dehydrated.
I say yes.
Really?
I agree with them.
Yeah, but what they really are saying is technically is they are volume depleted, and there's
Right.
a huge difference between the two. Dehydration is a term where there is a basically total body loss of water, both from the extracellular, what we call outside of the cells, and intracellular, inside of the cells, components. And dehydration is when you come in and your sodium is 154. That's dehydration. When normal sodium is about 140, so anything above 150 is significant dehydration. There's a difference from a man coming in, let's just finish, who is coming in with a sodium that is normal, 140, and yet blood pressure is low and the mucous membranes are low and everything else. That person basically lost fluid from where it matters, if you will, and they lost it from the interstitial tissues, and they need something back. And in that person's case, water would be good, yes, better than nothing, but this is where the sports drink industry lives. This is what it was invented for, meaning you get electrolytes. Yes, you want water, but you want some salt with it. It's your choice how you do it. It could be water and a salty snack. The best thing ever, since forever, has been chicken soup, right? That chicken soup as a hydrating liquid is the best. It's got water, it's got salt, it's got protein, it's got everything you need. And of course, Gatorades of the world and Pedialytes and other things are good. You are right in the sense that not always will they need IV fluid. Sometimes that kind of a situation is all they need.
Sometimes chicken soup is the best. Sometimes all I need is chicken soup.
Right. The question is, why did they get it in the first place? So a lot of times this will be because they've had a lot of diarrhea. They have a lot of nausea and vomiting. They can't tolerate oral fluids. But yes, oral hydration is in fact preferred in the hospitals. I don't know about your guys over there, but whenever I order an IV fluid, any IV fluid, I got a pop-up, both in Epic and Cerner, saying there is a general shortage of IV fluids. Please use hydration orally. It's actually a problem. We have a supply chain issue.
So we talk about now blood pressure in the setting of dehydration. You mentioned low blood pressure. How low is too low?
There is no number because it depends on the person. It's too low when you get dizzy or lightheaded when you stand up.
Yeah, I get people who come in oftentimes, they're older, many are older, and they say, I've been dizzy, I've been lightheaded. And they check in and maybe their blood pressure is fine, but then suddenly we get them to stand up and walk to the room and say, oh, they feel dizzy. We get them into their stretcher. You go from triage to the stretcher, and all of a sudden their blood pressure is 80/40. And like, well, sir, we find out why you're dizzy. Your blood pressure is a little on the lower side. And people understand that blood pressure, when it's low, blood's not getting to the brain as quickly as it should, which means the brain is not getting any oxygen, which means we start to kind of dial back some of the senses here. And that's when you feel dizzy.
And the brain, think about this, what dizziness really means and what lightheadedness means is the brain telling the muscles, I need blood. The best way for me to get blood, if we don't fight gravity anymore, I want to fall down. I want to get on the ground. So the brain executes, fainting episode is basically the brain saying, I need blood more than you need to be upright. And I'm just going to fall down. And guess what I'm going to get? You're going to hit yourself somewhere, but I'm going to get my blood. One way or
it's
another.
very selfish. The brain's a very selfish organ, as we're going to find out. I'm going to find a neurologist on and actually mention that to him, and he's probably going to give me shit, but it's fine. Now, okay, so too low is basically depending on the person, right? I have seen people who come in who are mentating perfectly fine with a blood pressure, sometimes like 74/30. And they're awake, they're talking to me, and we're wondering, how the hell is this possible? How are you not passed out? Why is your heart rate fine? This is weird. But then the counter to that is, how high is too high?
So just like on the low side, we don't have any numbers. On the high side, we have too many numbers. In other words, we have competing agencies from around the world that basically do different things. So if you want to look at the two main ones, although I'll mention the others, the main one is WHO and AHA. So WHO, World Health Organization, it's a global institution that kind of makes these rules and guidelines, and they said 140/90. So if you look at the WHO standards, that 140/90 is the beginning of hypertension. Being above 140 in the top number, the systolic, the squeezing number, versus 90, the diastolic, the relaxation number, you should be treating patients for that, or you're going to risk increased risks of stroke and heart attack. AHA, American Heart Association, says something different. They divide it up into stages, if you will. 120/80 is their perfect number, and there's going up from there. They're already saying that 130/80, you should start looking at treatment. They don't say medications right away. They say things like, hey, you know what, at first, why don't we just do lifestyle and stuff? But if lifestyle doesn't work, you should still treat over 130/80. And once you come to 140/90 for HA, you're already like in real stage 1 hypertension, and you really need treatment. You haven't just begun thinking about this.
So you hit 140/90.
Yeah.
You're stage 1 hypertension and you're on medication, it doesn't go down. Actually, you continue to increase over time. Are we adding on more of the same medication? Are you picking a different one? Are you like, well, maybe this doesn't work for you? How do you make that decision?
Yeah. So a quick primer on the medications when it comes to hypertension is this. When you're in med school, second year of med school, you do pharmacology class, we tell you about different classes of medications that treat blood pressure, and there's a lot of them, okay? There's at least 7 different classes. Each class has at least 5 medications. It's 35 medications that you have out there. So you say to yourself, wow, I have 35 choices. That's great. Turns out you really have 2 choices, just 2. You can even take this vessel and make it larger with medications. In other words, I told you, in health, it happens on its own. In disease, you can't do it. But if I give you the right med, I will force your vessels to open up larger. And the second option you have is to get the fluid from the vessel. And that's it. You could either take the fluid out or make the vessel larger. We don't really like messing with the heart itself. So that mechanism is pretty much out.
There are medications that affect heart rate. And by affecting heart rate, you're affecting the flow of the blood through that vessel, which means you're not getting as much force through there, which should also lower blood pressure. But that's more of a side effect as opposed to a true primary mechanism.
Yes. In other words, things like beta blockers and things which do that, we are also hoping that they will open up the vessels a bit and help us with that aspect of it. So to your question, what do we do when you 140/90 and you're on a 1 med? We like to add another med before we stop rising your 1 med. So from a patient's perspective, if you're on 1 medication, call a simple lisinopril, 10 milligrams, you go to the doctor and you would hope that they will just up your lisinopril, you're still at 1 pill per day, rather than now add another pill. But that's what we do. That's what's suggested. We want to try to get at the situation from different mechanisms, if you will. So what happens in most people is they end up on 3 medications. So I want you to know that 3 medications is normal. 3 medications at fairly low doses each is the preferred way of dealing with that quote-unquote resistant hypertension.
Now, we talk about high blood pressure and the risk for stroke, for heart attack, things like that. But there's another situation where patients' blood pressures rise, and it's due to a lot of factors, but then you have somebody with kidney disease coming in. And this is where we get in the emergency department a lot, dialysis patients. They're end-stage renal disease, their kidneys are failing, their kidneys are dead, whichever. They're on dialysis 3 days a week, and their blood pressures are 200/100. And for some people, they say blood pressure 200/100, and their brains are blown because they think their brains are going to get blown. And I have to counsel my patients, and even some of my newer nurses, where these people live at these numbers. It's okay, but is it really okay is kind of another question.
No, it's not okay in the sense that they are at very high risk of heart attack and stroke. There's no question about it. We have an agreed number where we think things are really bad, and that's 180/110, okay? It is, for most people, 180/110, you're at very, very high risk. Now, it doesn't mean that you will die that day. You see, I get panicked phone calls sometimes with this kind of number, 200/100, whatever, and they think they're going to die this moment. Historically speaking, we have a wonderful example in FDR. Franklin Delano Roosevelt died of exactly this thing. When he died of his brain popping from his untreated hypertension, he was at 250/150. So we know that 250/150 will kill anybody. So that is a number. If I hear that over the phone, that is like, I don't know what I'm going to do. Like an ambulance immediately, like this is imminent stroke.
They shouldn't be talking to you. If they're 250/150, they're probably not talking to you anyway, right?
Probably. It's probably there's somebody calling, whatever. But at 200/100, it's not an imminent stroke, but it's definitely hospitalization. Like, I would never let my patient call me from the house and say, that's my number, what do I do? I'd say, go to the emergency room. Because unfortunately, that is high enough for me to say, we need to be really monitoring you closely.
So you mentioned 250/150, 200/100 needs hospitalization. This is where a lot of my colleagues will disagree, because we'll say, well, if they're asymptomatic, they don't need anything. Oftentimes they'll come to the ER and they'll say, well, my blood pressure when I checked it was 200/100. Okay, well, how do you feel? Well, I'm fine. You don't have headaches, you don't have chest pain, you have dizziness. No, I feel great. And then they get angry at us because we actually don't do anything about that.
Right. So first, they would need to take their meds. Obviously, they didn't for the day. Sometimes they skip meds on purpose in dialysis, because sometimes we tell them not to take their meds because their blood pressure had been low on some other occasion. It's an interesting concept. The concept, which you're really referring to, is we have a concept of basically risk. The risk is there. The risk is not imminent, but it's there. And the question is, how is this risk managed? So when I'm, and this is a very interesting, this is where we clash. Where
Mm-hmm.
have a busy office, I don't want to have this potential next guilt thing on me, right? So I'm like, go to the ER. Then in the ER, you have a busy ER, and here's all these people coming. They don't need specific thing. What I really want is this patient to be, I guess, monitored closely for the next 6 to 8 hours. That's what I really want. I want to give him the medicine, whatever it is, and I want it to be monitored closely 6 to 8 hours. If we have a system where a nurse gets deployed to that room, to that house, hey, there will be a situation where I'm reassured and you are not having a busy ER. Problem is, we really don't have that system. But, in the end, we are both trying to do the same thing, which is prevent this patient from having this major event. And although 200 over 100 may not yet be there, if they mounted that pressure, nothing stops them from mounting 220 over 120 just an hour from now, and nobody will know it because now they are out of it. Like you said, they get encephalopathic and they can and then you find them in the morning in the room and that. So it's kind of interesting how we have different priorities, if you will, right? And and this is forever. This is like, I want to send them to you, and you want to send them to me, and it goes back and forth.
Yeah, and we say we got to. Well, it's like, well, but Doctor told me to come here. Well,
go see your primary.
Did you go see your primary? Yeah, it's the never-ending cycle. But I always love the people who come in at 3:00 in the morning, 1 a.m. in the morning, and they check their blood pressure. They come in and they say, my blood pressure was 180 over 90, and it's never been this high before. And I say, great.
Why are you checking?
Why you check your blood pressure at 3:00 in the morning?
I know.
And then it inevitably comes around to, well, I woke up and I was dizzy. Well, I woke up and I was having some chest pain, or I had chest pain. It woke me up, so I checked my blood pressure. And their focus, and again, we talked about earlier about, treat the patient, not the number. We have someone who's focused on the number. My blood pressure is high. I hear you had chest pain.
Yes.
How long have you had chest pain? That's what we have to evaluate. And I tell my patients, look at your blood pressure in many ways as a symptom, not as a cause. So if you're coming in, your blood pressure is 180 over 90, but you're having chest pain, I'm going to think to myself, is your chest pain causing your high blood pressure? Are you in pain and therefore your blood pressure is high? Are you having a heart attack and therefore your blood pressure is also high because all these hormones and chemicals are getting swept up in this current where your heart's not getting oxygen now. So, and that's the education I bring to patients. And the majority of patients, once they hear that, they understand that. The majority of patients, when they 3 a.m. check-ins with their high blood pressure, it becomes, okay, let's work you up for your why you checked your blood pressure, not the number itself. And then the smaller group, you had one read at home of your blood pressure being high. It's nothing to worry about. We're not going to do anything. Talk to your doctor. And then, you have your other subset there where, the blood pressure was like 200 over 100, or 240 over 120. And hey, you're having a stroke-like symptoms. And hey, by the way, you are having a stroke. And we need to get that number down immediately and treat what's going on.
Yeah, so blood pressure amongst all the other diagnoses in medicine is very strange. There's a few others, but this is very strange where it could worsen itself. So just the fact of having a blood pressure, knowing this stresses you out, and that in itself worsens the blood pressure. And it goes, and it's a cycle. It's a vicious cycle. I get a lot of phone calls, as a nephrologist, I get a lot of phone calls from people who are scared at home in the cycle. And I try to interrupt that cycle by just telling them, A, that they're going to stroke that day. B, come on over tomorrow, whatever. We'll look at everything and maybe adjust your meds. Diet is always a big thing. So we talk about that.
And it's funny, people think that we don't talk about diet a lot, that people are going towards other aspects of healthcare to talk about diet. And reality is, no, your specialists, your primary doctors talk diet a lot to you, but the expectation, I think, is, I want a medication, I want a pill, I want a shot, I want something that's going to work quicker than me cutting back on the pizza, for example.
Right. So the thing with this is this. Ask any patient in my office, ask any patient anywhere, do you want to, and I specifically use the word chemical rather than medicines because I want them to understand, do you want more chemicals? And they always say no. And nobody wants more chemicals. But unfortunate, human nature, myself included, I much prefer easy way out in life. So, it's the amount of discipline necessary for exercise regimen and a diet regimen is here, and the amount of energy to take the pill is here, and that's the differential. And some people are disciplined enough to do this. Most basically would like to not do it. So we have a triangle of discipline, chemicals, complications, and you get to choose your combination. If you have discipline, you don't need chemicals, and you will not have complications. If you do not have a discipline, you have a choice of taking the chemicals or having the complications. So that's where it's at. And for everyone out there who's screaming against pharmaceutical companies, they are meeting a need that we have, or we would have the complications, such as more heart attacks, more strokes, more dialysis if you didn't treat your blood pressure. But by all means, every single body of evidence, every single guideline producing body always says lifestyle modifications first. What does this mean? Number one, of course, weight loss. Number two, if you snore, check if you have sleep apnea. If you have sleep apnea, treat it. And that's right up there. That's not like number 7. That's like number 2. Okay, weight loss first, sleep apnea second. If you snore at night, if you wake up in the middle of the night and you just gasp for air, if your partner in bed tells you that you snore a lot, do not ignore it. You will have resistant hypertension if you ignore it, and you'll wonder why you need 4 drugs. Treat the sleep apnea, you're going to be on 2 drugs or maybe no drugs. And then, of course, diet. The problem with diet is this, Mark. If anybody wants to do this, please go ahead. There is a $1 billion opportunity out there. If you could create a restaurant chain that produces healthy food sustainably, that also hires physicians, doctors, nurses, nutritionists, and combines these 2 industries, the medical industry and the nutritional industry, together in one spot, where as a patient with blood pressure or diabetes, I could walk in and order fast, healthy, not too expensive food. That is an absolute business model. It's just so hard to do.
Well, we had that. We had that. It's because it's called hospital food.
Well,
it
right.
sucks.
So,
it sucks.
Yeah. So
you get a tray of, I order a renal diet, a cardiac diet, and what comes in the tray, people look at this and say, well, this is disgusting. Well, yeah, but it's better for you than the cheeseburger that you were hoping to order from.
The way I say it, one of my pet peeves is that patients who complain about this food, which, by the way, hospitals are trying to make it more and more tasty, but
they are.
I tell them, listen, if you're complaining about this, it just tells me that your palate is used to such volume of salt that is exactly what put you here in the hospital, Mr. Congestive Heart Failure with large edema and everything. You're here because of your choices. And the sooner you realize that this is the food that you should be eating and you accustom your palate to it, the less you will visit us here in this fine hospital. So again, it's a trade-off. And yes, I bet you could make tasty, healthy food. The problem is how accessible and inexpensive it could be, because if it's going to be some Trader Joe's fancy salad bar for $20 a pound, that ain't going to help.
Right. I would say it's going to help a segment of the population that probably doesn't need as much help as another segment of the population.
Correct.
Now, you talk about resistant hypertension. What do you mean by resistant hypertension?
So the type of hypertension doesn't get better with 2 drugs. So you're 140 over 90, I put you on 1 drug, you're still 140 over 90, I put you on the second drug, and you're still 140 over 90. Then you get labeled as resistant. And that changes things a bit, because then we start working you up for other things. So there is this term called essential hypertension. By essential, we mean blood pressure just because. I'm sure there are reasons for it, and we'll figure them out in year 2100. But right now, we just call it essential. That means it happened after you were 18, before you were 65, somewhere in there, 60, 65. So in other words, if a kid comes in at 14 with blood pressure, it's never essential. It's a problem. Work it up. But if a person comes in at 22 with high blood pressure, especially if they have family history of blood pressure, probably there's nothing else wrong with them. They just have high blood pressure. Again, we call it an essential, as in like idiopathic, as in like we don't know why. And we just treat that.
There's a term. I'm going to say idiopathic to patients. And they say, what does that mean? I said, I don't know. And they say, what do you mean? It's like, who's on first, right? No, idiopathic means we have no idea.
Correct. So on the flip side, if you've been healthy until 60, 62, and you never had blood pressure, and then you walk into my office with blood pressure that is high, I have to start thinking, oh my God, this is not essential. Something's happening. So what could be happening? Few organs: thyroid, most commonly, we check your thyroid numbers. Kidney disease, that's easy to check. Adrenal disease. So adrenal glands produce all these specific hormones that basically control the blood pressure, and sometimes they overproduce them. And basically we need to find that, because you may need surgically removal of the adrenal gland if need be. There are other things involved, sleep apnea being one of them also. So by second resistant, we mean we start looking for what's called secondary causes, i.e. is there a specific organ, specific condition in you that could be fixed specifically with surgery, or in case of sleep apnea with a mask or whatnot, that will then take this cause away, and oh my gosh, your blood pressure is normal now without all these meds. So that's what we do.
And then, of course, those patients are probably more likely to be high risk for stroke, heart attack, things like that, than somebody with just pure essential, I'm on one medication hypertension.
It's all about control. Blood pressure is all about control, because like you said, it's a symptom. You could argue that that there is some core aspects to hypertension, but in the end, what it is it doesn't matter what the problem was. If you control the actual pressure of each heartbeat hitting those blood vessels and hitting those organs, if you control that, you will reduce the risk.
And that's one thing we do when we have patients coming in for a stroke, for example. It could be two types. You could have a blood vessel in the brain that popped for whatever reason, versus a blood vessel, a part of the brain is not getting oxygen because there's a clot there that, blood's not going through. We have two ways of looking at blood pressure. If the blood's not getting into where it needs to be, we actually allow blood pressure to stay high because we want that force to get into the rest of the brain as much as possible. But when there's blood now in the brain, now we want to bring the blood pressure down. So you don't bleed as quickly, and so we have time to control the bleeding. So it's interesting that we talk about managing blood pressure. We have a lot of medication. We have 30-some plus medications that can control blood pressure one way or the other. And at some point in medicine, we use all of them, depending on what we want the blood pressure to do. And in the ER, I can control blood pressure like that. Instantaneously, I can say your blood pressure is going to go from 200 down to 100 at the push of a few buttons by my nurse. I don't know how to do a pump. I have no idea. So my nurse is going to put the medication, program a number, and it's going to drop. And for people that are used to, quote unquote, used to a blood pressure 160 over something or 180 over something, their blood pressure goes down to 120, 100. They say, I feel dizzy. Yeah. And it's like, yeah, you do, because your brain is configured in a way that those blood vessels flowing in there are used to a certain pressure. You take that pressure away, and suddenly the blood vessels are what's going on. It's a very small amount of blood going through a very large opening. The brain doesn't know what to do, so it reacts and starts to feel dizzy. Even though that blood pressure, now it's 100 over 70, is probably what you should be at, but now all of a sudden, this is weird. I don't know what to do now.
Yep, and same thing happens to the kidneys, called autoregulation, where the vessels basically protect themselves from the onslaught, if you will, of a high blood flow, high pressure for a long time, and they develop a certain mechanism. And then when you take away that onslaught, they will adapt again, but it will take time. So just like it also slows down.
I do want to do a segment on strokes in the future, but that will require finding a neurologist to come on, and that's I'll search on LinkedIn or something like that and figure somebody out. But But good information. I think hypertension, blood pressure is for many of my patients at least, a misunderstood phenomenon about what we treat, why we treat it, what we don't treat, and what are the causes of it. And certainly stress and anxiety are a cause, like the white coat syndrome. People walk into a hospital, a doctor's office, their blood pressure spikes. But they also have to understand that diet and exercise are one of the first drivers of hypertension to begin with. And taking care of yourself does a lot more than any pill would do. Once you've already reached critical mass, once you've reached, the 2 or 3 pill regimen, then we gotta, obviously you're beyond weight loss and exercise, but not entirely. I know many people who they get their weight under control, their lifestyle under control, and suddenly they're down to 2 medications, 1 medication, off medications. And
correct.
There we go. So, Dr. Tracz, thank you so much for coming on. I really appreciate it. Hypertension, like I said, it's a very complex thing, very misunderstood thing, but everybody has some degree of issues with blood pressure, whether it's too low, too high. So I think we need to educate more to our patients and do a better job educating, at least from the ER and primary care standpoint of the world about this. And hopefully this can be a bit of a wake-up call for a lot of people out there who maybe have ignored early, like low stage 1 hypertension and thought, it's fine. But reality is it's a big deal, especially as I get older.
Right. So let's just leave our audience with 3 very practical pieces of advice. For diet, you're looking at you have to look at the labels. You look at the sodium content and try to stick to things that are 250 milligrams of sodium or less. So that's on your diet front. 250 milligrams of sodium per serving or less. On the exercise front, the good old 10,000 steps, whatever, put in good amount of walking per day at the very least. We talk about 150 minutes of moderate exercise per week if you really mean business. I should be doing 150 minutes of exercise a week. That's well-established number. But if you can't do that, at least walk, 30 minutes a day, every day. And 3, again, back to the snoring, which is an epidemic that's completely estimated. If you snore, check yourself for sleep apnea because it plays a huge role in blood pressure.
I want to talk, eventually I want to get you back on here. I want to talk about hydration, dehydration, but I think I want to touch more on the sleep apnea aspect of it more, because that's something I actually have to look up, because I'm always a little bit like, how does sleep apnea trigger high blood pressure? Sure. So I think that's going to be a segment in the future if you're interested.
We need a sleep guy for that.
Yeah, that's true. So if you know, here's the thing too, if you know somebody, because I don't know sleep guys, right? They're not coming to the ER. If you know somebody, refer me. That would be good.
All right.
Good advice. Dr. Tracz, thank you very much.
Yes, thank you.
I'm going to put that information. I already put it in the video as far as text information for those who are watching this, but I'll also put it in the comment section, in the description section of the video, as well as on social media too. That's information people need to be aware of. So once again, Dr. Tracz, thank you so much for coming on.
Thank you.
I really enjoyed it.
Pleasure.
And hope to get you on next time. So
yes,
take care.
I think this is a lot of fun, Mark. All the best, okay? Take care.
Thank you. Take care.
Bye-bye.
All right, that wraps up another episode of the JAFERD Cast. Thanks again to Dr. Michal Tracz for joining me, nephrologist, hypertension specialist. We talked about hypertension. We talked about what it's like to undergo training, some of the trials that doctors face when they're coming up through their training process, and of course, tidbits on a healthy lifestyle in general. Thanks again to him, and we are always happy to have him back here to talk about other issues as well, including things like dialysis, dehydration, so we'll see him again. If you enjoyed this episode, please don't forget to like and subscribe and turn on notifications. I love constructive feedback, and ultimately this show is designed to help you, the listener or viewer, make informed choices regarding your own health and to help raise awareness of the issues facing healthcare at large. You can leave your thoughts in the comment section below for those on YouTube, or email them to me at jaferdcast@gmail.com. If you're in the healthcare field and interested in being on the show to discuss topics in healthcare, please feel free to reach out as well. If you have ideas about topics I should cover that are in healthcare that you want to hear, please email them as well. I'm always open to suggestions. As with anything, don't take my word for it. Do your own research, talk to your own doctor, and remember, at the end of the day, I'm just another fucking ER doctor. Make your choices, everybody.